fine. That's what he keeps saying. He has just suffered a massive, high-impact fall directly to the pavement. Underneath the skin, the physical reality is severe. The muscles are enduring the immediate aftermath of blunt force trauma, feeling sore and beaten to the bone. Yet, as you approach to offer assistance, he waves your hand away and insists you go help someone else. He refuses the doctor entirely. This behavioral pattern, where the mental state actively masks the physical reality, is the specific tension we find at the center of this drug picture. Identifying this specific reaction allows a practitioner to begin the process of matching the patient's state to the recorded symptoms of Arnica Montana. To understand this denial's mechanics, we look to the Boericke Materia Medica, reference L3035. We use this text not as a simple list, but as a systematic clinical dataset. Our strategy is to work backward from this observed behavior to uncover the root pathology. We must deconstruct three distinct layers of the patient's state: the psychological mind, the physiological sensations, and the etiological trigger of the injury itself. By mapping these data points, we establish the exact boundaries needed to distinguish Arnica from its closest clinical neighbors. Navigating this multi-layered map is essential for maintaining diagnostic accuracy in the middle of a high-stress, acute trauma scenario. We begin with the psychological layer, focusing on the patient's rigid state of denial. It is easy to mistake a patient's claim that they are fine for simple bravery. In this clinical context, however, that claim is a manifestation of profound systemic shock. This shock creates an intense dread of being approached. If a practitioner tries to examine the injury, the patient instinctively retreats, fearing the slightest touch. This psychological wall acts as a defense mechanism erected by the nervous system to protect a hypersensitized and damaged body. A practitioner must therefore treat the patient's denial as a key symptom of the trauma, rather than a factual account of their physical condition. Moving from the mind to the body, we find a specific set of sensations that emerge when the patient attempts to rest. The core somatic experience is one of being beaten. Every muscle feels bruised, a sensation that seems to penetrate deep into the skeletal structure. This is the hard bed keynote. Any surface feels like stone. Red highlights show points of contact where pressure is unbearable. The result is relentless restlessness. The patient shifts constantly, hunting for a soft spot that does not exist, expressing deep muscular soreness within. This observable shifting provides a reliable diagnostic indicator, especially when the patient's internal shock prevents them from describing their pain in words. To complete the map, we look at the etiology, the specific injury vectors that produce this tissue response. Primary triggers are blunt force impacts, the sudden stop of a car crash, a hard fall, or a heavy blow. The same tissue response can be triggered by non-accidental trauma, such as the physical overexertion of a marathon, the strain of childbirth, or the mechanical impact of surgery. These events lead to a visible pathology known as ecchymosis. We see the trauma bloom over time as blood pools under the skin, creating the characteristic black and blue bruising. In classical homeopathy, Arnica is the primary responder for these specific types of blunt muscular injuries. Success in the clinic depends on matching this blunt force history to both the visible bruising and the invisible psychological shock. Applying the same remedy to every trauma case overlooks the critical differences in how various tissues respond to injury. We use this comparative framework to rule out other remedies based on the depth of the tissue and the nature of the injury. Arnica's scope is focused. It is best suited for blunt trauma that impacts the superficial muscle layers. If the injury vector reaches beyond the surface muscles, we must look to Bellis perennis. Bellis perennis is the primary choice when the trauma involves deep tissue, specifically within the abdominal cavity or the pelvic bowl. When the trauma involves a break in the skin rather than a blunt blow, the focus shifts to ledum. Ledum is indicated for localized point injuries, such as cold puncture wounds, where the tissue damage is concentrated rather than widespread. Precise prescribing requires us to identify the exact mechanism and depth of the injury, moving past the general concept of trauma. When we step back, the complete picture of the Arnica patient becomes clear. This visualization shows the contrast at play, a body enduring the physical reality of a crash, while the mind operates under the illusion of denial. To use this in practice, verify the blunt etiology, look for the physical restlessness of the hard bed, and recognize the patient's denial as a symptom of shock. In practice, always watch for the traumatized patient who immediately waves you away, stubbornly refusing the doctor, and comment below on which remedy differential we should map next, and subscribe for more Materia Medica deconstructions.